Good afternoon. I hope people had their lunch or probably are not very hungry. so, um, so we're going to have a session on renal tubular acidosis, and I would like to invite Dr. IPS Kocher, who's a well-renowned pediatric and adolescent endocrinologist at Indraprastha Apollo, New Delhi. And sir, please chair the session. Sir would like to introduce the speaker, please.
So there is no need for any introduction. Dr. Professor Bagga, head of pediatric nephrology at AIMS New Delhi, and he at presently he's director of pediatrics in Apollo Hospital Delhi, and well-known figure in pediatric nephrology. So everybody in I think over of India and many parts of the world they know him. So I request Dr. Bagga to please carry on with it.
Thank you, sir. Thank you. So we'll begin. The plan is, that over the next 45 minutes or so, I'll give you a overview about the pathophysiology, the evaluation and diagnosis of RTA. And then my colleague, Dr. Srinivas, he'll be talking to you briefly about therapy, and then we'll take questions together. So renal tubular acidosis is not an uncommon problem, in pediatric nephrology. And any of you would know this picture. Who is this Dickens character? Anybody? This is a novel of 1843 or something, So this is Tiny Tim. And Tiny Tim is, in the novel Christmas Carol, pointer है यहाँ पे, pointer दे देंगे या ऐसे इस श्रीनिवास इससे कर लेंगे, ठीक है, पता नहीं ये भी चलता है नहीं ठीक है, I think this is fine. Srinivas, it's okay. Yeah. So Christmas Carol, he's a character who had deformities, and nobody is aware. The hypothesis is that most likely he had RTA, although I think there are people who would say that he probably had tuberculosis and so on. So I'll briefly discuss the physiology of the kidney in reference to acid-base homeostasis. So you do know, that whatever each of us, when we are taking a diet every day, we do produce about 1 milliequivalent per kg per day of acid. And the more animal protein you are taking, the more acid you are making. The other source of acid production is that when the bone is being laid, when you are forming bone hydroxyapatite, bicarbonate is being absorbed, is being utilized. So clearly these are two acid forming ways by which the body would require some kind of buffering. Now the function of the kidney or the nephron is chiefly two. One is to filter the almost 5,000 milliequivalents of bicarbonate that is being filtered every day by the glomerular. So this is being done chiefly by the proximal tubules. And the second is to neutralize the acid that is being made every day in the body through dietary acid as well as the hydroxyapatite that's being laid down, particularly in children. And the entire nephron, but chiefly the distal tubule is more involved in being able to secrete the acid. So bicarbonate regeneration is chiefly a function of the distal tubule, whereas bicarbonate reabsorption is a function of the proximal tubule. And there is active proton secretion happening across the whole nephron, but chiefly the distal tubule. And the proton secretion happens through three ways. One is free hydrogen ions that you measure as urine pH. The other is through titrable acids, which is H2PO4 chiefly, so HPO4 becomes H2PO4, and most importantly, the secretion of ammonium. So hydrogen ion secretion happens through these three ways, and the body is able to get rid of extra acid in the body. The chief ions, and I will not go into too much details here, I don't want to bother you post lunch with all this, is the sodium hydrogen exchanger on the luminal side and the sodium bicarbonate exchanger on the basolateral side. And these are responsible finally, for reabsorption of sodium, reabsorption of bicarbonate. And obviously the two key enzymes here are carbonic anhydrase, which is there in the cytosol, Ca2, and Ca4, which is there in the luminal fluid. And these are important, channels through which sodium and hydrogen ions are being reabsorbed or secreted. please do understand, and this is an important point that you need to figure out, is that once you get hydrogen ion secretion that is happening proximally or even more distally, this hydrogen ion combines with the bicarbonate to form H2CO3, which is broken down to water and CO2. Therefore, the amount of CO2 you get in the urine in the distal tubule, from the distal tubule, is a marker of hydrogen ion secretion. So if you do not have enough hydrogen ion secretion happening in the distal tubule, you will not get enough CO2 in the urine. And that's the reason why you use the difference of U minus B CO2 when you're looking at the hydrogen ion secretion in the distal tubule. Over the years, apart from the two standard channels, NH3 and the NBC1, a number of other channels have been hypothesized, and all of them have been now linked to the occurrence of Fanconi's syndrome. So you may, and they are shown here, I will discuss about them later, but there is a host of other genes that are now defined which can cause the Fanconi renotubular syndrome, and they are being defined more and more. So clearly there we have a definition of the causes of proximal bicarbonate reabsorption defects. Now in the distal tubule compared to the proximal tubule, you have two different kinds of cells. One is the principal cell, which is chiefly involved in two things: sodium reabsorption, which is happening across the ENaC. And for the endocrinologist, you would know that ENaC is obviously the gene that's affected in pseudohypoaldosteronism and so on. And obviously, you've got sodium reabsorption happening here. This is under the control of aldosterone. And then absorption of water across aquaporin channels. And the second important cell in the distal tubule are the alpha intercalated cells. And what the alpha intercalated cells are doing is that they've got a hydrogen ATPase, which is a very potent secretor of hydrogen ions. And this is able to secrete hydrogen ions in the luminal fluid. There is also a hydrogen potassium ATPase, but it's perhaps not that important. The hydrogen ATPase is far more important on the luminal side. And on the basolateral side, you've got the anion exchanger that exchanges bicarbonate for chloride. Now, all these are important, so please keep them in mind. So you've got the hydrogen ATPase here, you've got the anion exchanger here. And because these are the two commonest genes that are affected in distal renal tubular acidosis. The third cell is the beta intercalated cell, which is really the converse of the alpha intercalated cell. I will not go into too much detail on this, but it really is kind of doing the opposite things. And there is a lot of plasticity in the sense that alpha cells could become beta cells and so on, depending on the body's state of acidosis or oblique alkalosis. The final slide on this is how is ammonia made by the kidney and how is it excreted. Now this is a slightly complex process. Ammonia is synthesized chiefly in the proximal tubule from glutamine, and each molecule of glutamine leads to production of 3 molecules of ammonium or ammonia. This ammonia is then secreted in the luminal fluid. So it goes inside the lumen. Inside the lumen, it then comes down into the thick ascending limb, wherein it gets reabsorbed by the NKCC2 transporter, the transporter that gets affected by furosemide. And so it goes into the medullary interstitium, contributes to the medullary interstitial hypotonicity, and thereafter it gets secreted as ammonia in the distal tubule. And now when it comes in contact with hydrogen ions that are being secreted by the alpha intercalated cell, as you can see here, it comes out finally in the urine as ammonium back. So there is a lot of recycling of ammonium. So there is a proximal ammoniogenesis and there is a distal secretion. And so clearly this does get affected by the acidosis and alkalosis as well. We know that when you get hyperkalemia, the ammoniogenesis is reduced. So hyperkalemia leads to acidosis and vice versa. Now for clinicians, when would you suspect RTA? And so this is, I'm sure you're well aware about this. If you've got short stature, failure to thrive, motor delay, multiple episodes of hypokalemic weakness, fractures, rickets, liking savory or salty products, polyuria, polydipsia, and very rarely hypertension. I don't know whether we've written hypertension here, but hypertension is a rare, but not really in RTA. It's a very rare kind of RTA that would happen. And obviously then calculi and nephrocalcinosis. So these are the various, clinical syndromes, clinical situations wherein one would suspect renal tubular acidosis. And the biochemical scenario could be that typically you've got a hyperchloremic or a normal anion gap metabolic acidosis. You may have hypokalemia and acidosis, which is so often, and we'll discuss this later. And obviously, in the situation of PHA, where you've got a pseudo-hypoaldosteronism, particularly the type 4 RTA, you would get hyponatremia and hyperkalemia. So any of these syndromes, one should just keep in mind, that this child could be having RTA. The most important, the first step, in recognizing RTA is to look at once you do document that the patient has got acidosis and he has got a low bicarb, is to look at the anion gap. And I'm sure this audience is well aware about the importance of anion gap. And the normal anion gap is chiefly between 8 to 16 or 8 to 12 milliequivalents per liter, 8 to 12 chiefly, And the common causes of a normal anion gap acidosis are listed here. Another way to kind of look at this is to look at the ratio of chloride to sodium. And a chloride to sodium ratio of more than 0.8 is again a normal anion gap metabolic acidosis. You have conditions wherein you could have an increase in anion gap acidosis, which is listed here. So I will not go into details on this, but the first step in evaluating metabolic acidosis is to look at the anion gap and define whether this is a normal anion gap or an increase in anion gap acidosis. Now, once you have a normal anion gap acidosis, so you have got metabolic acidosis with a low bicarb and therefore a high chloride, and that's why we call it hyperchloremic metabolic acidosis. How do you evaluate further? And we'll just go through the steps with you here. So the first step is to look at the urine pH. And when you do a urine pH in somebody who has got acidosis, and if the urine pH is high, if it's say more than 5.5, it would suggest RTA. This should be a fasting and a fresh sample. So don't take an old sample wherein you can get bacteria proliferating and so on. But remember always, that the urine pH is only looking at the free hydrogen ions. And I told you, hydrogen ions are being excreted as titratable acids, ammonium, and free hydrogen. So you're just looking at the free hydrogen ions when you're looking at urine pH. What are the caveats here? The caveats here are chiefly two. The first caveat is, suppose somebody has got acute diarrhea and he's reabsorbing a lot of sodium. When you've got very low urinary sodium, you would have less hydrogen ion secretion. So when you have less hydrogen ion secretion, the urine pH may be high. So in a state of acute diarrhea, with low urine sodium, you may get a high urine pH. So don't go on labeling it as RTA. The second situation is an absolute converse. Suppose you've got a patient who's got chronic metabolic acidosis due to whatever reason, but his kidneys are fine. So his kidneys are fine, therefore they're making a lot of ammonia. They would mop up all the free hydrogen ions. So you would get a lot of ammonium in the urine, but the free hydrogen ions will be rather minimal, So again, the urine pH here would give you a wrong diagnosis of RTA. So both in acute diarrhea as well as in chronic metabolic acidosis, you just can't rely only on urine pH to make a diagnosis of RTA. So it's an important test, but keep the caveats in mind. And you know that Proteus, you can get a high pH Proteus UTI. So the tests that we do to look for urine acidification ability are two tests. And I will not go into details on this. You can take a copy of the slides later. It doesn't matter. The standard procedure really involves giving ammonium chloride, 0.1 gram per kg of ammonium chloride, and then looking at the urine pH over the next 6 hours. And this can be done, this is a simple test that we have all been doing at academic centers for years on hold. You can use ammonium chloride, you can at times use calcium chloride, but ammonium chloride is more commonly used. And you're looking at your endpoint is being able to achieve a urine pH of below 5.3. So ideally speaking, when you load a patient, the urine pH should fall down to below 5.3. And if you reach this pH, the kidney is acidifying normally. Problem kya hai with ammonium chloride test is that ammonium chloride is a tough molecule to take. Kids vomit, they may have problems. So by times, doing an ammonium chloride test is cumbersome. And therefore, over the years, the test that we use instead is the furosemide fludrocortisone test. Again, here the aim is the ability to acidify the urine when you give furosemide plus fludrocortisone. What furosemide does is, it leads to increased distal sodium delivery. And when you have got an increased distal sodium delivery, you will have an increased hydrogen ion secretion. And you are promoting sodium reabsorption by giving fludrocortisone. So you have got high sodium in the lumen of the tubule. This sodium will get reabsorbed due to the action of fludrocortisone. And because all this is getting absorbed, the hydrogen ion will get secreted. So a normal kidney, when you do this test, would be able to reduce the urine pH to below 5.3 again, or 5.5 or 5.3, whereas a patient who has a distal tubular dysfunction would not be able to reduce the urine pH below 5.3. So this is a good surrogate or a substitute to the ammonium chloride test. It's got a very high negative predictive value, as you can see here. However, most purists would say that one should be doing the ammonium chloride test after the fludrocortisone. But I must say, that very often we stop here, we don't go to the ammonium chloride test. If the pH doesn't fall, we say that distal tubular secretion is perhaps not very good. The other test, that's been discussed a lot is the urine and ion gap. And please remember that the urine and ion gap is really an estimate of the urinary ammonium, because you do know that the anions are equal to the cations, and the chief cations are sodium, potassium, and ammonium, and the chief anion is chloride. Bicarbonate becomes an important anion only once the pH of the urine is more than 6.5. So that's a caveat here. So looking at the urine and ion gap, which is the difference of sodium plus potassium minus chloride, gives you an indirect estimate of the urinary ammonium excretion. So a normal individual who is acidotic would have a negative urine and ion gap because the ammonium excretion is high. Is this part clear? On the contrary, somebody who has got RTA, because the ammonium excretion is not adequate enough, they would have a positive anion gap. There is no use doing an ion gap in somebody who's got normal acid-base status. This is only applicable if you have got hyperchloremic metabolic acidosis. Okay, so this gives you an estimate of urinary ammonium excretion. Another way to estimate this is the osmolar gap, but I'll leave this for the moment. Won't bother you with this. That's also the other way by which you can estimate the urinary ammonium. The problems with using an ion gap are one or two, and the chief problem that's been seen over the years is the ion gap depends a lot on your dietary intake of animal versus plant products. People who are taking more animal products would have a more acid urine, and vice versa, So there is less and less interest in the utility of an ion gap in the algorithm. So while we will talk about it, but I think overall, and there is clearly a consensus now that one should, if you really want to estimate urinary ammonium, please estimate urinary ammonium directly by standard labs, rather than relying on a surrogate. But even I'm aware, that most experts would still use an ion gap in the algorithm. The third test that's often employed, when you're trying to evaluate a proximal versus distal RTA, is what we call the bicarbonate loading test. Now in bicarbonate loading test, what you are doing is that you are giving enough bicarb, either orally or IV, so as to saturate the bicarbonate reabsorption. And then you're looking at two things, and we'll talk about those two things. And you try to saturate this by giving oral or IV bicarb in the doses that I mentioned here. I would often prefer using the oral dose and raising the plasma bicarb to about 20 and or the urine pH above 7.5. So this is an important test, and I would still say that in academic centers, when you are evaluating patients, one should probably be relying on this test. Having said this, given the amount of importance that we now rely on genetics, and this test being cumbersome, because you need to now be able to estimate the gases on the urine sample. Most labs don't do this. So it's a test that's not so easily done. But when you do a bicarb loading test, you look at two things. You look at the Fe bicarb, and Fe bicarb, is the urinary bicarb by plasma bicarb, the whole divided by urinary creatinine by plasma creatinine. So obviously you need to do a urine gas, and most labs are not happy doing your urine gas on a blood gas analyzer, because they say that membrane kharab ho jayegi, something else may happen. So clearly this test is, while it's a good test, it's not often used. But you can estimate the Fe bicarb, and normally Fe bicarb should be below 5%. In patients with proximal RTA, the Fe bicarb would be clearly higher. The second thing what this test does is that when you are in a bicarb loaded state, you look at the U to B CO2 difference. And remember, I told you in the first or second slide that the distal hydrogen ion secretion is a measure is estimated by the urinary CO2. So if you've got distal RTA, the urinary CO2 would be low, and the difference would be below 20 or below 10 or at times even negative, compared to say a normal person where the difference in a bicarb loaded state would be high. But again, while we talk a lot about this, but there is these tests are tough to do, and one does require, and normally I would say that don't rely on a single test, do at least more than once, and always try to run a control simultaneously. It's always good to, even when you're estimating urine pH, and when you're doing a urine pH, don't use the pH paper, use the pH meter instead, because pH paper is far too gross to be able to pick this up. So and again, always it's good to always have a healthy control, because, and this could be a parent, this could be some other patient's relative, and so on, because otherwise to rely on biochemistry in our labs is not very great. Now, proximal RTA compared to distal RTA is really a part of Fanconi syndrome. Most patients who have got proximal RTA in fact have the entire Fanconi syndrome, and Fanconi syndrome really implies the presence of tubular proteinuria and amino aciduria. Now these are they have to be there. You can't have Fanconi without amino aciduria and or tubular proteinuria. Other things, glucosuria, sodium losses, calcium losses, this is variable. This may not always be there, but you do need to show that there is tubular proteinuria. Not the albumin, but the tubular proteins like retinol binding protein or beta 2 microglobulin and so on. If you are seeing a patient who's got hyperphosphatemia, one would have to look at the phosphate handling. And there are various tests. I'll not bother you with but then clearly, you're supposed to estimate the Fe phosphate and also estimate the TMP by TMP, that is the tubular maximum phosphate, by GFR, which can be done either by using a formula or using the standard BOVA's nomogram. And again, these things, if you do them once or twice, you get used to them. So please don't get overawed by all these tests. They are done, they are practically feasible. And the final step, when you're evaluating the etiology of RTA, is to look at the potential secondary causes. So I'll probably so what's this? Any idea? Cystine crystals on slit lamp in a child with cystinosis. And what's this? The typical faces of Loeys syndrome. Very good. Cataract in a patient with proximal RTA or galactosemia. We know that the NBC channel, the sodium bicarbonate cotransporter, can have cataracts as an important manifestation. Dense bones, calcification in the brain, RTA. Type 3 RTA, carbonic anhydrase 2 deficiency. In fact, there is nothing like mixed RTA. Mixed RTA is the only genetic cause is carbonic anhydrase 2 deficiency, and the only two drugs that can mimic this is astazolamide and topiramate. They can again cause a picture like type 3 RTA. So, but then if you get intracranial calcifications and you get dense bones, one would think about carbonic anhydrase 2 deficiency. This is obviously very simple, that you are seeing elliptocytes. This is the anion exchanger defect. The SLC4A1 defect, a feature of type 1 RTA, the anion exchanger defect. Always remember, and you don't need to go through this list now, always remember that there is a list of conditions that are acquired causes of RTA, both type 1, type 2, type 4 and so on. And always remember that conditions like FSGS, obstructive uropathy and so on, where you have a congenital anomaly in the kidney or you've got an acquired anomaly, is not renal tubular acidosis. So always keep these things in mind. Over the next few slides, I'll talk briefly to you about the genetics of RTA, because clearly this is one area that has changed the way we understand RTA in a major way. And the key genes that cause RTA are listed here. We talked about the hydrogen ATPase, which is shown here, the anion exchanger that's there. Then there is FOXY1. FOXY1 is the Fockhead box I1 protein, which is a new gene that was discovered about 6 years back. This again, can cause distal RTA with early onset deafness. and we'll talk briefly about WDR72 later. So these are the chief genes that cause distal renal tubular acidosis. So you have the SLC4A1, which is the anion exchanger gene, the three hydrogen ATPase genes. Although there is still some doubt about whether the C2 subunit really causes RTA or not. And then you've got these two genes that are listed here. And we have discussed this, so you can get deafness and RTA with the FOXY1 defects. Overall, if you look at patients with distal RTA, about 75% would show a genetic defect if you were to do the genetic analysis. So 3/4 of all children with distal RTA would show a defect. There is a small proportion of orphan distal RTA where we still don't know the gene, and there are a number of genes are proposed, and but currently we still are left with these genes, and they are listed here. This is a study from Italy wherein they showed the common defects. We won't go into details on this, and we'll briefly discuss this later. And the similar data was seen from another European cohort wherein they showed this. If you just go back to this thing, the genes that are the hydrogen ATPase genes, they have early onset deafness, chiefly with the B1 subunit, less often with the A4 subunit. And as we said, the deafness is also there with FOXY1. Hemolytic anemia may happen with some of the anion exchanger. So be aware about these genotype-phenotype correlations. This is recent data from JIPMER. Again, talking about the same thing all over again. Look at the genetic scenario here. In Europe, it appears that the hydrogen ATPase is the key gene. But clearly data from India seems to suggest that it's not hydrogen ATPase, but it's the anion exchanger. This is born from data from JIPMER, from the large ICMR database in Bhopal, as well as data from the institute that talks about SLC4A1 being the commonest gene. And the overall spectrum is shown here. This again is, why I'm spending some time is because clearly genetics is a very important tool. We had a IPNA symposium just about 2 weeks back, and the last line or summary was that in RTA, it's genetics, genetics, genetics. So you have to be able to evaluate your patients carefully. So don't kind of disregard this. This is important information. This is the way you are able to define them better. And the therapies also depend a lot on what you are able to diagnose on the genetic evaluation. And there are some clear clinical phenotype and genotype relationships, deafness and etc., all being parts of certain conditions. The other thing to understand is that a proportion of patients who have got RTA, this particularly distal RTA, may go on to progress to chronic kidney disease. This figure varies between 16 to 20%, depending on which center data from where you are seeing. This is data from India. Sukanya was one of our students. It's her thesis, and she's currently doing a DM in endocrinology with Rajni. And she looked at almost 130 patients of RTA or follow-up, again finding the same genetic background and showing that almost 75% of patients with distal RTA, there was a genetic defect compared to 95% with the Fanconi syndrome. So clearly keep these things in mind. And the latest gene, that's kind of come into this picture has been WDR72. These were kids, who presented to us with amelogenesis imperfecta, and you can see the teeth here. Clearly lack of formation of the enamel, and along with distal RTA, they did not have deafness, and they had a very mild rate-dependent RTA. This data has been summarized and recently published in pediatric nephrology from JIPMER, reporting almost 20 patients from across the country, again showing marked amelogenesis imperfecta, polyuria, rickets, and so on. So depending on the genetic defect, if you have sensorineural deafness, you can think about certain genes. If you've got amelogenesis imperfecta, then it's more like WDR72. Ovalocytosis or hereditary spherocytosis, anemia with the anion exchanger. And then, other forms can also lead to other forms of clinical symptoms. So this is based on the genetic profile. In addition, and the main clinical features of distal RTA would be the presence of hypokalemia, hyperchloremia, because the chloride levels will be high. In addition, these patients also show hypercalciuria in a very large proportion. They would have hypocitrate urea because when you get acidosis, the citrate gets reabsorbed. And because you've got hypercalciuria and hypocitrate urea, you end up getting stones. So clearly, that's a consequence of the distal renal tubular acidosis. And finally, rickets and osteomalacia. One problem, that is often asked as a question that concerns endocrinologists as well as nephrologists is that you have patients with distal RTA who in addition show some proximal dysfunction. Now, what is this? Is this a mixed kind of an RTA or what, And over the years, we have understood that when you have an acidic milieu, you do get proximal dysfunction even in patients with distal RTA. So patients with distal RTA may show low molecular weight proteinuria. They may at times show hyperphosphatemia. Glucosuria for some reason is uncommon, but I've recently seen a patient, who also had glucosuria. So acidic milieu does lead to proximal dysfunction, and as the acidic milieu gets better, when you treat these patients become better, and finally the proximal dysfunction goes away. We'll let this. I think it might be a bit too much, Is there a condition called incomplete RTA? And this has been a issue that's been discussed a lot. These are patients who do not show baseline acidosis. Typically would be seen in adults with osteoporosis, patients with stones, and a high urine pH, and so on. A host of conditions. Now, these patients do not show acidosis when you evaluate them, but they may have any of these underlying conditions. But when you do an acid loading test, like ammonium chloride test, or you do a furosemide fludrocortisone test, they are not able to acidify the urine as well. Now, what do these patients represent? Nobody knows, There has been some feeling that perhaps these are heterozygous forms of the autosomal recessive disorders, and maybe they're not really the homozygotes. But again, this is extremely contentious. And there's been not recent, but editorial a few years back asking if incomplete RTA is really a real disorder, or is it just a part of a spectrum from normalcy to RTA, and incomplete RTA is somewhere in the middle, But once you do diagnose incomplete RTA based on the lack of ability to acidify, then you would treat them with citrate and so on. Very briefly about Fanconi syndrome. The term that's being increasingly used now is the Fanconi renal tubular syndromes. Although, initially, if you read the literature, it does say that renal tubular syndromes chiefly have involvement of the kidney per se. But most recent literature would also include the Fanconi per se in the Fanconi renal tubular syndromes. And the conditions are listed here. You are well aware the ones that are underlined are the ones that are much more commoner than the other ones. And there are a number of genes now that are known. But this you can only figure out, once you have the underlying cause. And I'm sure Srinivas will discuss briefly about the management. So I will not go into too much detail here. And this is another paper, talking that Fanconi renal tubular syndromes, you would really have to rely on genetics to be able to define a precise disorder. They would have a lot of common overlap, with amino aciduria, low molecular weight proteinuria, phosphate uria, glucosuria, potassium losses, urine sodium losses. So you do need to do genetics to be able to figure out what the underlying cause is. We can take this in question answer, I think, because we are almost now 2:15, so maybe we can leave this here. But very briefly, the type 4 RTA is fortunately less common in children compared to adults. But type 4 RTA is really a situation wherein you have got aldosterone deficiency or aldosterone resistance. So the key tests in a patient who has acidosis with hyperkalemia would be to look at the aldosterone levels, look at the renin levels, and so on, and try to define which category they fall. So in summary, so if you get a patient who has hyperchloremic metabolic acidosis, one could do a urine and iron gap. If it's positive, consider renal tubular acidosis. Look at the urine pH, look at the serum potassium, and if possible, do a bicarbonate loading. In patients with proximal RTA, the urine pH will be low. The serum potassium may be low or normal. The U minus B PCO2 will be high, and the Fe bicarb will be high normal. So this would be proximal RTA. One would need to evaluate these patients in more detail with genetics. Type 1 RTA or the distal RTA would have a high urine pH. Serum potassium may be low, normal, or at times could be high. The U minus B CO2 level would be low because there is inadequate hydrogen ion secretion happening in the distal tubule, and the Fe bicarb will be normal. And again, you will need to evaluate these patients for hypercalciuria, nephrocalcinosis, stones, and so on. And if you're thinking about a precise genetic defect, evaluate for hearing and so on. And we did discuss briefly about type 4 RTA, wherein you have patients whose serum potassium levels are high. The urine pH is below 5.3, and the other acidification parameters are normal. And here you would need to look at the plasma renin and aldosterone and evaluate for kidney disease. This is more commonly seen in adults than in children. I'll stop here, and Dr. Srinivas.
First of all, I would like to thank sir for giving me this opportunity. Moving on to the next part of the talk is the management of children with renal tubular acidosis. Whatever diagnosis we make, either a distal or a proximal, there are certain aspects that should be that are common in managing these patients, which includes the correction of the metabolic abnormalities, delaying disease progression as they have been reported to progress for chronic kidney disease, nutrition and growth, which is a bread and butter of all pediatric cases, and management of the comorbidities with the renal tubular acidosis. So moving on to the first metabolic abnormality, which is the metabolic acidosis. Children usually, when they are present for the first time, can present with an acute decompensation. In that aspect, when we have to first calculate the bicarbonate deficit, which using this equation, and the most commonly used IV medication is the soda bicarbonate, which is given at a dose of 1 millicoulomb per kg and has to be diluted in 5% dextrose. And various techniques are there to give IV infusions, but the recently recommended is to give the total deficit over 2 to 4 hours. So once we are stabilizing these patients with the acute decompensation, the next step is to...
Most kids would recover based on standard, bicarb supplements. So it's not a routine. Unless somebody is clearly vitamin D deficient, that's a different thing altogether.
I think most of the kids will be deficient, because...
Yeah, but then, but very often we end up not using, because there is hypercalciuria and so many other things are happening. So we are worried, So maybe perhaps, acutely one may still give, but overall we still are extremely careful.
No extra amount of vitamin D.
We do not.
Yes,
we do not.
So one small question, what is the difference between treatment point of view proximal versus distal?
So the differences are multiple, One is obviously the dose that Srinivas mentioned. The amount of bicarb that you require in proximal would be clearly higher. Proximal would require very often phosphate supplements. And these two are much more important. Hypercalciuria is a problem more with distal than with proximal. So salt intake, while you're trying to curtail, you really can't go overboard because these patients are also craving salt. So chiefly in terms of, the alkali supplements, the phosphate supplements, anything else? Yeah. And then there are specific therapies may be possible for some forms of proximal RTA, like cystinosis, Fanconi Bickel, tyrosinemia, and so on.
So just a couple of points. One, how often do we need to use thiazide on follow-up on distal RTA now? I think most of them improve.
We don't use thiazides at all. In fact, I've seen problems, Anurag, of patients who had distal RTA, and when you add thiazides, you also end up giving them Gentleman syndrome. Yeah. Theoretically, and you end up getting more hypokalemia. Yeah. So we would hardly ever use thiazides, and once you give them enough bicarb, the hypercalciuria does get better.
And carrying on the point with Dr. Kochar about proximal RTA, we find it extremely difficult to correct their phosphorus levels and bone.
So do remember that the phosphates will hardly ever cross 3.1, 3.2, 3.5 bhi pahunch jao, achhi baat hai. Because, there is obviously a threshold beyond which everything will leak out. So, but even 3.5 is fine, being able to achieve that by giving multiple doses. And obviously giving enough bicarb and more repeatedly. Yeah.
Thank you.
Have you seen any difference between Jolly solution and neutral alphos in the response?
Previously I was using Jolly solution, when we did not have neutral, the ADFOS available. And our adult endocrinologists were using neutral phosphate. So there was a time we began with Julie's, then neutral phosphate, then we had Adphos. But I think Adphos generally does reasonably okay. You need to give enough amount. Again, your target has to be 3.1, 3.2, 3.4 perhaps milligram per DL, and you need to end up giving about 50 to 70 milligram per kg. But I must say that the tolerance has significantly improved.
But
But
maybe
Julie's,
it's better.
we used to have
Tolerance
problems.
is much better at first
With
as compared to
Adphos.
Julius.
Yeah, पहले तो बच्चे
Which
उल्टियाँ
is,
करते थे. They would
neutral.
vomit.
Yeah,
Yeah.
So for urinary and iron gap, what is the sample that should be preferred? Is it a spot sample or a 24-hour sample?
You can do either. In fact, I was checking yesterday. You can do either, but I would generally prefer doing a spot. But please remember the caveats I told you about an iron gap. Don't go overboard on an iron gap. An iron gap overall, many people would now feel that it does not add much to what information you're getting from pH. So while doing an iron gap is physiologically sound, so when you're doing it in a hospital setting, it's different. But बहुत नई information नहीं मिलती है.
And my second question will be for Sister Gonza. So do you recommend doing a leukocyte cysteamine levels? We have recently started cysteamine for few of our children and we don't know where to get it. And
It's currently not possible. We began doing it at the institute, Again, we could never do it. I don't know anybody who's doing leukocyte cysteine. I think briefly, it was done in Mumbai and then perhaps in Bangalore or Hyderabad. But currently, I don't think anybody is doing consistently. Ideally speaking, one should be doing leukocyte cysteine. You want to add something?
Usually, as the recommendations are to monitor with the leukocyte cysteine levels, and the units are also slightly different. Actually, track the leukocytes separately and to do it's a little cumbersome process as well.
I think we can close now because
Sir, one more question.
So,
Yeah.
Okay. Last question.
Yeah. Sir, in the acute metabolic acidosis, you mentioned the formula is 0.5 into weight into 24 minus BICA. So should we target the value of 24 because it came out to be very large? Would not it lead to be hypocalcemia, or should we target the value as 15?
So actually that is the total deficit which has to be corrected.
Yeah.
That 0.5 is also, there is a recent review where they have mentioned actually the actual equation is 0.4. But there is something called a virtual bicarbonate space where there is a dissipation of this bicarb into the intracellular as well as the free acids available in the blood. So that's why the equation has been modified to 0.5. Usually, even if you correct this over 4 hours, you won't achieve the target of 24. You will be gradually building up. So that will not directly reach your value of 24 anyway.
So should we target giving the dose over the period of 6 hours, not a strat dose?
So actually there are various regimens followed. Previously we were usually following, you calculate the total deficit and the half of the total deficit would be given over 8 hours and the remaining over 16 hours. But recent even various recommendations have suggested to give this over 2 to 4 hours.
Thank you, sir.
I think we can close now because the time is finished. Give big applause for, very nice.
Thank you, sir, and thank you, Dr. Srinivasan, for a very nice presentation. I request Dr. Rajni to please felicitate our chairperson and Dr. Bagga.